For the last talk at the COMy meeting, which is tomorrow morning for me, which is a kind of a review of the IMiDs, a best of, if I should put it this way, of the IMiDs in 2016, 2017. What my talk is going to be really discussing would be two major, I think, improvements that we've had with the IMiDs. Use in the past 1, 2, 3 years. The number one is the systematic use of Revlimid as a backbone in the relapse setting, in the early relapse setting, first relapse, second line, third line, where we've had tremendous results, reaching levels of PFS that we've never had before, definitely as good as upfront, with PI and IMiDs. Novel generation PI, proteasome inhibitors like ixazomib and carfilzomib, respectively, Tourmaline MM1 and Aspire. And most recently, the POLLUX data, where everyone would agree that the data are absolutely groundbreaking. Although Dara-Revdex was conducted anti-progression with all what we've discussed before, which is the burden of continuous treatment, but still the results are here to convince everyone that this is clearly making an enormous improvement in taking care of the patients. And so daratumumab, Revlimid, Dexamethasone end up with 78% of the patients have not relapsed at 18 months. This is unseen so far. So in that regard, it's very interesting. And it convinced us that triplet is needed. It convinced us that it is manageable, even until progression, and that if you want to make a big improvement to myeloma, it comes to this kind of approach. That's so number one, triplet Revdex in the early setting, a relapse setting with PI or with monoclonal antibody, and particularly anti-CD38 daratumumab. So second big aspects of what we've learned from IMiDs comes to upfront. For the upfront setting, we've been running a lot of continuous treatment. It's always this notion of continuous treatment that comes back to mind and to our approach. In transplant eligible patient, post-transplant as a maintenance, monotherapy Revlimid, which is now approved, especially in the US and in Europe, based on a meta-analysis of 3 different clinical trials, gigantic clinical trial, phase 3 trial, randomized, where patients were randomized placebo, no treatment, versus Revlimid as a maintenance post-transplant. And the meta-analysis clearly demonstrated that 7 years later, you would have a 12% improvement in overall survival if you have used maintenance. There is still a question whether this maintenance should be run until progression or for a limited period of time, and this will be answered by several studies ongoing in the future. But the concept of giving a maintenance post-transplantation is now completely validated, accepted by everyone, and part of the guideline. Philippe Moreau has inserted this concept in the ESMO guidelines, which he mentioned at IMW. The parallel version of that is in non-transplant eligible patients. Nothing really new, but of course you have to mention this, which is the first IFM 20701 or MM020 study, where we also, in a similar fashion, demonstrated that continuous treatment with Revdex was manageable, feasible on the long run, and would benefit to the patient in terms of PFS and overall survival. And for the MM020 first study, has completely eliminated from the landscape of the non-transplant eligible patients upfront the MPT regimen, which is clearly dead. The new standard of cares are either VMP, which was there for a while, or Revdex, Revlimid, Dexamethasone, Lenalidomide, Dexamethasone, which is now the new regimen. Now, as a future perspective, I'll conclude showing a slide with all the ongoing clinical trials. And it is obvious that bortezomib alfanoprazole is rapidly going to be replaced, I believe, by lenalidomide dexamethasone. And the reason for that is that it's hard to improve VMP. It's already a triplet-based regimen, and melphalan with its alkylating agent effect is a little bit cytopenic, more cytopenic than lenalidomide dexamethasone, I would say, especially on the long run. You cannot run VMP for a long period of time. While Revlimid dexamethasone is a platform for development that is very easy to run for triplets and potentially quadruplet in the future, even in non-transplant eligible patients that would be fit, with a safety profile that we imagine that we anticipate that could be better than VMP. So the last slide, conclusion slide, will be a summary of all these clinical trials ongoing where Revlimid dexamethasone is systematically the control arm and the backbone for the combination.